you know, and then I think zooming out from that, going back to the flexibility or going back to that, this is a 10-year term. So the decision you make, like how flexible is it and how long are we committing to that decision? So.
If I can now speak on the employee medical center, one of the thing, the proposal of Aetna saying that, hey, you know what, we know you want to expand and that's going to take some time. But in the meantime, look at all these locations that you can use basically as employee medical centers that are already in existence and have those same benefits that they would if they went downstairs. A lot of the things that we deal with in wellness is the vast land of Hillsborough County. And how do you get these types of services out to employees? They really liked that part of the Aetna's proposal on that. That was strong for me. I might have more comments.
Anybody want to take first shot?
Really? We'll take a shot.
I don't think we're ready. I'm taking shots.
So I have a few questions I'd like to ask, if that's all right. Kind of circling back to pre-authorization, if I missed this when you were speaking and I didn't catch it fast enough. So currently, right now, we can choose who, we can make our own pre-authorization list.
For some low-level services.
Some low level.
Yeah, I want to make it very clear. It's not for like prior authorization for surgery. We're just going to say, yeah, Ivy, you can have your lung transplant. We're going to make sure,
So,
you know, so.
so based on what services we currently have set for pre-authorization, how did the two that said no, and they gave a list of what the pre-authorization services compare?
It's a pretty big deal. Because, and I will tell you, it's on imaging and advanced imaging and radiology. And if a doctor is ordering it, we turn the switch back on, let's say, I don't know, 4 or 5 years ago, maybe, you know, it was when Mike Merrill was here. So several years ago, we turned it back on for a little cost saving measurement. And it was an absolute nightmare because everything was going through prior authorization. It was taking 7 to 10 days. And, you know, it really was, it was unnecessary. So we kind of went back to the same philosophy that we had, that if a doctor feels that an x-ray is needed for this, they should be able to just go and have it done. Now, I will say, preface that with an MRI, they can't just, that still is something that has step therapy. So in our system currently today, and they have to do the x-rays first before they can then go get the MRI. So it's really just removing that step, that once a provider has already done the first step, the second step, and now we're going to the MRI, they can just order the MRI and the person can go.
And the reason I'm asking the question is because since the framework is what we have now or better, the question is, okay, how many, like, you know, ballpark number, like, let's say we have 25 services that are pre-authorized now. It could be higher, could be lower. I'm throwing out examples.
Yeah.
But in the responses for Aetna and for UHC, when I looked Aetna's up online and I did a count, I didn't like go line by line. Did they align with each other? But you know, Aetna has 33 services that they're saying require pre-authorization. UHC has 48 services. So I was wondering how that compared to what we require now, if it's a higher or a lower number.
It's definitely a lower number, I would say, because a great deal of prior authorizations has to do with like the MRIs, the PET scans, the CAT scans, not so much
Certain
the
surgeries,
X-rays.
it's like, you know.
Oh, yeah. And then obviously, probably a great number of those 33 and 48 are things that are like medical service, patient hospitalization type of services that are a little bit more, you know, need a little bit more medical guidance and.
But even it's interesting, like just going back to the philosophy of we've got to go with what they wrote, and they wrote very clearly, no, we can't do it. So listing the
This
things.
is what our list is compared to what we have now.
Comment.
Right, and that does differ from what we heard yesterday, but so like that matters, but like it was no, you can't, and that, so we know that.
No comments.
Right.
That helps. Thank you.
Yes.
And then another question for you. And again, it's just understanding the overall framework of why it's important. You there's two of the responses for Aetna and UHC came underneath in a 90% auto adjudication for claims. Why is that important to the county or to its employees?
Thank you. I was going to ask that question.
What did you say, Tom?
No, I agree.
Adjudication of claims.
Yeah. Well, first of all, we have a high volume of claims. Bindi can attest to that. Hundreds of thousands of claims at least per year. And auto adjudication is an efficiency. So we don't hear a lot of noise from employees when a claim, because it's automatically going through. And so, and you could probably help a little bit.
I was just gonna, can I jump in?
Oh, sure. This is how their systems are set up. A clean claim just goes straight
Right.
through.
And how many, I'm sure everybody in this room has got a balance bill before, right? Where you got this bill and how many times have you called? And they're like, oh, no, actually, it's not that we haven't paid it. We just haven't paid it yet. Or, so if the doctor in their accounting practices to the hospital or whomever is sitting on a claim for a certain number of days or a time frame, they're just going to start billing the member. Doesn't mean it hasn't been already sent and the carrier's not thinking about it and getting to it. But in a auto adjudication process, that is a quicker turnaround time, less likely for the checks to cross in the mail, right? But when there's a manual process, the opportunity for the member or the end user to have an experience where they think the doctor's telling them they owe something and they don't, or the hospital and they don't. But Becky, is that fair?
Yes, it's definitely
And on
fair.
that, to that, like auto adjudication could be approved and denied.
Yeah, it doesn't,
Oh,
It's
definitely.
not necessarily just.
it might be denied quicker. Yeah, that's actually a really,
Because the auto adjudication system has certain things set up and
Right.
the claim has to go through it. Anything that gets kicked out could be a denial because it's not
Right.
going through.
and that's super fair to look at it always. It's not assuring that less claims will be denied. It's assuring that they're going to be evaluated quicker,
Yes.
right? And
Based on the.
we're not saying manual is bad either. There might be a really good reason why there should be a manual review of this claim. But certainly the longer time it takes for a provider to get their money, the more likely they are going to be sending out a bill to a member.
That explanation helps. Thank you very much.
Manual adjudication also is done by human beings, so it
Yeah.
also
Yes,
introduces more opportunity for error.
Great
to
point too.
happen.
That's right.
Longer time, built-in standards, yeah.
Yeah.
Mhm.
Well, it kind of what stuck out to me is, you have two that are at least a few or the case, a handful of percentage points underneath the 90% mark that we have here. And I was just curious if there would be a business reason as to why it might be at a lesser, is like more manual oversight, like kind of what might be playing into that. So I was just trying to better understand of the framework of, we're calling for a 90% auto adjudication. It's good to know it's both, approval and denial, meaning it's going into automatic review, and then how that impacts our employees downstream as well as our benefit teams.
So I have and maybe this is too simplistic of a question. I'll preface this by saying that. The idea was to meet or exceed what we currently have. To our advisors, how do you feel each of the proposers, do they meet, exceed, or do not meet what we currently have? Is that a fair question?
You mean overall?
Sure.
I don't think that with every single facet of our health plan in every single category, that everybody's gonna be able to do exactly what we have today. So this example, the 86.4%, I don't think is a deal breaker at all. But because it doesn't meet what we currently have in our performance guarantees of 90% within, I don't know, what is it, 5 to 7 days? I can't remember. 7 to 10, 14, what? I can't remember, but I would say everybody pretty much met, but some met better than others. Some came closer. And I'm talking minute, very minute details.
I found, I
Because there's thousands of things that we have in our health plan.
Let me ask it a different, or let me, and maybe we're not ready to move on to this, but we talked about deal breakers, right? With that, and that matters. Innovation does matter too. Like, right? We know, we did ask everybody to give us like, or, similar, or call out where. We also asked for a lot of innovation. Would there be an innovation deal breaker that we couldn't live without? Like, is there something that somebody said that others didn't, that maybe we can't live without in the next 10 years, right? I think you got to look at, so we talked about the deal breakers, unless there are more, then I think we got to flip that a little bit and say, what innovations do we really need? And did someone propose that better than others?
Well, and from the other evaluators, before we move on, were there any other things for your evaluation that you saw, Tom, Irma? Were there any things?
Yeah, I mean, I went through the questionnaires and I tagged the ones where there were differences in responses. And I think it's just about every one of them.
Okay, perfect.
Go ahead, sorry, I missed that.
Yep, that's okay. Just wanted to make sure before we jumped onto innovation that there wasn't anything for you guys that.
And I think
Yeah.
Nicole brought up a good point, that innovation matters and we've got to think about it, because it was a lot of our questions, but what's the cost analysis of that, right? And I think that's a conversation with all of us. So like, we're going to talk about innovation, maybe from the technical advisors, like what's really, or even the committee, what did we hear that's super important to us? Are we willing to give up what we might be? Then we got to think about what those deal breakers were. Which one matters more?
Yeah.
Okay. Any innovations that were like, wow, we can't live without that?
I think, Chris, you made a good point. I don't know if anybody else had,
Oh, did I? I thought we closed that.
didn't know if anybody else had anything else. Deal breakers, things that you saw.
I don't know, deal breakers. I guess, are we able to discuss what the difference is between Cigna's proposal versus what we're currently getting? Are we moving forward? Are they
Offering what they have now.
what we have currently versus any changes that they've proposed? What are the major changes from our current experience?
I wouldn't say anything from a service perspective. I did see some charges that we don't pay today. They're minimal. But then again, there isn't the amount they're giving us that I can't say. So,
That would cover.
because that kind of balances it out and not, it's.
And also, I think they changed the pass-through model, right? So you have, your pharmacy is
Oh, that's
moving to
true.
100% pass-through.
Yes.
So they have to process those claims differently, right?
Yes.
So yes, you're, I think kind of to your point, it was, are we moving forward at all? Yes, I would say you're not losing anything. There may be fees in places where there weren't, but that's because there are opportunities for wins in places there weren't.
From an
I think that was in
employee
pharmacy, right?
experience,
Yep, it was in pharmacy.
Yeah.
from an employee experience with the other two carriers, do we see any pluses or minuses?
I think I would repeat kind of what some of the deal breakers were earlier for the team, is the 24-hour service. And maybe some disruption in end user experience filling prescriptions, or having to get a prior authorization for an image, an x-ray that they didn't today.
And some of the concierge services that.
Yeah. Yeah.
And it, we
Go
have today.
Yeah.
That we wouldn't have with one of the other companies. That's concierge service with United.
Yeah. Now, I think to be fair, those responders also, speaking to your population, like I think both of those responders talked about, or not your incumbent, right? They talked about programs specific to like fire or to rescue services. That's different, right? That's an enhancement, but it's not those things aren't necessarily available all hours of the day or night. Like,
Put a lot of weight on that. As far as for us, we've developed our own peer support network. We've vetted our own clinicians. And so while it looks great on the slide, I don't necessarily put a ton of value on it.
and
Currently Cigna does offer us a responder program.
oh, my apologies. Okay. Okay.
Well, as he said, isn't really utilized.
Okay.
Yeah.
that we're receiving is going to be different it's at our discretion rather than where it's currently set up now. So there's a difference with Cigna, other fund. We
There's
get
more freedom there.
Yeah.
Innovation.
A very open-ended question.
Yeah, that is a very
Today, was there something in these proposals that piqued an interest as far as an innovation goes?
Can you remind me, and I apologize because I didn't bring my computer with me, this behavioral health enhancement that we saw yesterday from Cigna, was that included in their original proposal? or
Yes.
was- It was.
as a buy-up. So they said, if you can
Yes.
keep what you have today, or you can add on this and you can use the bucket for it. Yes.
Speaking from a wellness standpoint, I really like that idea to be able to take some of the bucket of money and being able to buy up and offer behavioral health services, not just to those on the health plan, but to, what they were saying, how that's going to work with everybody, as well as having a mental health provider on site. I can tell you that we get a lot of requests for mental health providers through different departments that go through really scary stuff sometimes. And that is a really important thing that we could actually take that provider and get them out there that day and get them the help that they need. And that includes, I'm sorry, I'm going to get probably too deep into this, but that includes things like they're threatened, they're, things like that. We're able to respond. That would give us the ability to respond faster. It would also give us the ability to have somebody professional working along with strategy and developing the mental, emotional health strategy in the wellness program, which I found that to be very beneficial in my thought process of strategy. So that would be, and that was offered as a buy up, so that is available to us if we want to buy it up. So I didn't see that in the other two proposals.
I think the innovation that I'll just point out just for dialogue is something that we've talked a lot with the HR team and strategy is like kind of the copay plan and finding some opportunities for an affordable yet first dollar coverage plan. And everybody has something. United Healthcare has a proprietary solution that is tech enabled and they included it in their proposal. And that's cool. And it is innovative. And just knowing that that's something that we've talked a lot about in some of our strategic planning as the consultant. Like, I just think that matters. And what did you guys hear when they brought that up and how relevant do you think it is to your population?
I think significant. I think people would choose a doctor that would cost them the least. That's still a good doctor versus not knowing and just showing up to an office or no matter what quality the doctor is.
Yeah.
You pay what you pay.
We have trouble getting our employees to read email. So that was my biggest thing is a lot of them aren't involved in tech or even want to be involved in it at all. So it's nice, but population.
It's only as good as
Right.
its
If
utilization.
people aren't using it, what's the point?
I think that's a valid point, and I think it's also interesting to note that people often aren't as involved in their own healthcare and trying to save money. I mean, we all kind of work in programs that are geared toward that, so we understand some of the other side of it, but typically consumers are not as interested in, they just show up at the appointment whatever doctor's in the list. And, they just aren't going to seek out the lowest cost for the best value, high quality provider, for themselves. They're just, I want to pick up the phone, call somebody, make an appointment. There we go. It's just kind of cut and dry a lot of times to people, sadly. And honestly, people are busy with a lot of other things in their lives, so they want something to kind of be taken care of for them. So I think many of us in this room would definitely utilize an innovative program like that, but I don't know that our general population of people would utilize it especially if it costs a lot more
Yeah.
to.
And that's my question. Was
Well-
that a buy-up? Did we really get a?
It's a future opportunity for plan design. It's not gonna, well, there were some changes in administrative fees in there, but it's not gonna cost you more to add something like that. I would say might help from a claims impact perspective.
I was gonna say, like, when we talk about cost though, we still have to price out from an actuarial perspective,
Yep.
what a program like that would cost.
And I would just touch on to your point of like, you guys absolutely know your population and you are, I think, everybody in this room is more astute than most, even private employers we work with. I will tell you that concern that you share, if the carrier that made that proposal was sitting here today and had an opportunity to discuss that with you, we hear that across the board. It works and there are ways. I'm not saying it is right, but I just devil's advocate, right? I just want to play or not play, like make sure that we're communicating that there are solutions and opportunities to educate to make it work if it was a value to you. And I think every employer that has ever been presented that option is like, I don't know how we would use it. And there is a success rate with what they're doing. But again, it's not at the sake of what were we giving up in other areas, and if it's not a hot button or top priority for you today, that matters. I want to just do a quick time check just because of course we're going to spend as much time as we need to on this. We only have about 30 minutes left today. So if we think we need to keep talking about it, and Christy, I'll let you.
You're reading my head. So we're at about the 4:30 hour. Don't think you want to stay until you solve all of this, being after 5 o'clock. I'm not sure if you think you're in a place to score. If you are, do we want to take a look at those items that make up this category and start going through them and scoring and throwing out scores? Or do we want to make a call that we need more time for discussion? I don't want the committee to feel rushed or like they can't make a call. We have another meeting on the 18th, and as Scott talked about, really at the end of the day, the value of this is there. But if you feel you have enough information to start scoring, I think maybe we need to look at where we're at and maybe the criteria that we have for this bucket. We need to sit here and focus in on the ASO questionnaire and attachments, PBM questionnaire and attachments, concierge service questionnaire, wellness services questionnaire, the AP behavior health questionnaire, come up with some scores and get them down on paper and figure out that we're going to score them, or make a call that we don't have enough for today to finish it out. I think we're at that point where we've got to pick one or the other.
I'm okay with scoring.
I'm okay with scoring.
I would be okay with scoring.
I'd be surprised if we can finish it in half an hour.
Say that again.
I'd be surprised if we can figure it out in half an hour, but.
I'm okay with scoring.
Okay, I mean, I've gone, as I said, we've covered and hit everything. I think there was a difference and talked about it. Are we talking about, when you talk about the scoring, I mean, you're not talking about scoring each of those individual areas, you're talking about just an overall score on the
Just
60.
an overall score. If you're there, we're there, 65 points out of 65 points. Mike, I'm gonna give you first.
I don't want to go first.
Sorry.
Oh, I have Cigna at 62, Aetna at 60, and United Healthcare at 58. I exactly placed
Say it again.
62 for Cigna, 60 for Aetna, and 58 for United Healthcare. That was based off of the non-negotiables that were on my list. I deducted a point for each one of those that each provider wasn't able to provide.
I put Cigna at 63, Aetna at 60, United Healthcare at 55.
Can you say that one more time? 63.
Cigna at 63, Aetna at 60, and United Healthcare at 55.
I had Cigna at 63, Aetna at 60, and United at 56.
I can go next.
Okay.
I'll have Sigma at 62, Aetna at 60, United Healthcare at 57.
I'll go. I have Cigna at 62, Aetna at 59, United Healthcare 58.
I had a much different process. Basically, I took all three of them, I ranked them a plus, a neutral, and a minus, and went through all of them. I ended up with Aetna at 52, Cigna at 43, United at 35.
One more time, sorry, 52, 43, and
35.
52 for Aetna.
Okay.
43 for Cigna, 35.
thank you.
I do want to just add a quick comment with Cigna. I mean, to me, it seemed like they gave a lot of flexibility in terms of, possibly pursuing, narrow networks, controlling your pre-authorization list.
Controlling the budget.
Yeah, your copay only design. I mean, we have a very diverse population, among our employees. And I think this level of flexibility will give you greater control to be able to find or develop different plans that will continue to appeal. 10 years is a long time in this industry. And especially to stay competitive and retain employees, I think it'll give greater birth to develop those plans.
To be fair, I defer most of my opinions to the people that deal with the inner workings. For me, a lot of it's employee experience. I think it's great having the wellness center here. I think having the minute clinics all over the county, you get a map of where the firefighters live. It's, Pinellas, even up to Gainesville, all the way down to Manatee with, 47 stations throughout the county, that to have a clinic basically on every corner is significant.
Now, just to be clear with those clinics, you can visit those under any of the.
Sure. I think there was some discount to it though. There was some experience difference.
Yeah, I'm not sure there. I don't remember.
Well, I look at it as the annual wellness visits, and that's at zero cost, no matter what.
And we use LifeScan for that.
And you guys use LifeScan, that's right.
Is it Cigna at 60? I was split from everybody else. I was at United at 56 and Aetna at 52. I can change my mind.
Do we want averages?
So I guess,
You got them not though, right?
well, I was going to say Cigna, the range was 10, you had a 43. Everybody else was somewhere between 60 and 63.
With an average of 59.29. If that matters. Sorry, I had that, created that for us. We started with that.
We had
You have the other averages.
Yes, Aetna was 58.14, United 53, even.
So, let me see, Cigna, we had 3 scores of 62, 2 scores of 63, 1 at 60 and 1 at 43.
And with averages, we had 59, 58, 53. Yeah, the average is correct. Yeah.
I'd be willing to come down to 62 for Cigna.
What did you have?
I was a 63.
Okay, sorry. I should've-
I could go 62.
I was a 63, I could go 62.
I was a 61, I'm willing to go to 62. Sigma.
So 62.
Everyone's
62.
at 62 except.
Okay.
But I mean, Tim, what
What were the others? Was there any change in anybody else?
I think everybody else was already at 62.
I had 62.
Yeah, so that's all 62s and then 43. And the average 59.29. I set them up, so thank you.
It doesn't really change anything as far as front runners. What's consensus on all three?
what consensus on Cigna seems to be here 62.
Mhm. I would say majority on Aetna was 60. You've got 4 60s. A 59, 52, 56. Majority on UHC. There's 2 58s.
Otherwise, mid-50s.
Yeah.
Looks like 62, 60, and 58.
60.
Well, you are suggesting.
62, I think.
62? 60.
Is the committee agreeing for a score for Cigna of 62 on category 1?
I would go to that, yes.
Yeah.
Good. To me, to be good.
Yes, I'm good.
For Aetna,
Aetna, there were 4 60s of 7. So 52.
59, 56.
56.
No,
What's
it was
the
two
average?
52s,
Oh,
52s, yeah.
252, sorry, and then a 56.
59.
59.
The 56 was
Change
United.
over here. Oh, boy.
What's the average?
So let me just repeat back to everybody. We had 4 60s,
Mhm.
a 59 and 2 52s,
Yeah.
57.57.
I can come up to 60.
You were 52?
I had a different methodology.
Sorry, I thought I was doing this while I didn't write everybody's name. So now I'm like, wait, where was he?
I'm good with that. I can admit I missed some stuff.
I was 59, I'm willing to go up to 60.
Okay, so 58.86. So now we're, rounding up. Well, that leaves us all 60s with 1 52. And
No.
that-
No,
56.
we're 60 across the board.
56.
Yeah, we're not yet.
Okay, Jean's done.
Can you, yeah.
We're agreeing that.
Don't put this on the calendar either. For us. Yeah.
Now 60 for Aetna.
Yes.
Yes. Okay, committee, everybody?
Yes.
Yes.
So it seems like maybe United should be 56, 57.
I'd be willing to come up to 56. I was at 55.
We're not yet 56.
What was
So the outline score was the 35.
what's the,
So 56.
is there anything with that?
A 58, 2 58s.
And a 57.
Mhm.
Your methodology, I guess I was at 58 then.
All right, that changes our average. So let me repeat back. We've got 58, we got 3 58s, 2 56s, a 57 and a 52.
No. 58,
Wow, did I go wrong?
I screwed up. I
58.
got mine backwards. So
56, 56, 57,
Uh-huh.
58,
Yeah.
58. No, 50. Oh, shit.
Oh, boy.
Meet in the middle and say 50 and then something and then a 56. Yeah. You don't like
How about we
58.
just flip back up and let the committee get scores.
Should we just,
57?
can everybody maybe
We've
say
got
their score again for UHC?
Come to a consensus.
We got
50.
The average is in.
Go Tom.
We got a couple of 58s and then we've got a couple of people below 50, 56 or 50, 57. They're on 55, 56. Almost seems like 57's meeting in the middle.
I would agree to 57.
It was 57.
So we have all the committee members agreeing to a score for United Healthcare on category 1 of 57.
Yes.
Yes.
Yes, I'm good with that.
Just checking. Just want to make sure everybody agrees.
All right.
Okay, so I am going to go ahead and announce the consensus scoring to make sure that the committee is in agreement. So I will go ahead and take care of that now. Give me just 1 second to make sure I have this together. Okay, so I'm going to do this by proposer and I will start off. I'm just doing this alphabetically. It's the way it says in the system. So on your consensus scoring for Aetna, criteria 1 was the proposer's understanding of the scope and objectives, technical approach and work plan. I have a score of 60. Section 2 or category 2 was the quality of proposed system and its ability to achieve the objectives was a 14 out of 15. And the pricing and discounts was an 11 out of 15. And then the proposer's organization qualifications and experience was a 5 for a total score of 90. Is everybody in agreement?
Yes.
Yes.
Okay, that proposer did submit for the DWBE bonus points. They did get scored by the team and it was given the 5 extra points. So their total score comes to 95 points. Okay, for Cigna Health and Life Insurance Company, category 1, I have a total score of 62. Category 2, I have a total score of 15. Category 3, a total score of 13. And in category 4, a score of 5 for a total of 95 points. Is the committee in agreement?
Yes.
Yes.
They also submitted for the bonus points and did receive the 5 additional bonus points. Or I'm sorry, for a total of 100 points. All right, and last we have United Healthcare. For the criteria 1, they received a score of 57 consensus. For category 2, it was a consensus of 10. For the pricing and discounts, it was a consensus of 12. And for the experience and qualifications, a consensus of 5 for a total score of 84 points. Is everyone in agreement?
Yes.
Yes.
They also submitted for the bonus points and received those bonus points. So their total score today is 89 points. Do we have anybody that has any questions at this point? Okay, so just to confirm and repeat, we have Aetna at a total of 95, Cigna at a total of 100, and then United Healthcare at a total of 89 points. If we don't have any other questions or concerns from the committee or anybody else, we can go ahead and conclude this meeting. And we really appreciate everybody who's taken this time out of their regular work schedules to do this. We know it's not always easy, especially on something this big. So we really do appreciate your time and energy that you put into this. And thank you for being part of the process. Oh, yes. Committee members need to hang out for a few extra minutes. I need to print the scoring sheet for you and have you guys sign before you leave. So if the committee members could hold off for a minute, otherwise I'm going to end the meeting. We're good to go. Thank you.
Thank you.